Hello, coders. So we are talking today about urinary system surgery and male genital system surgery. So like most of our other surgeries, we can look them up by the name of the surgical procedure. So we can look up things like nephrostomy, we can look up vasectomy, prostatectomy, things like that. We can look up the anatomic sites of either the urinary or the genital system, and we can also look up different conditions such as a polyp that we could find within the systems. So most of our main terms are going to be either the body parts or the testing itself. So we have to remember that as we're going through the urinary system, we start at the top and move down to the bottom. So we're going to start with kidneys, then we're going to get to the ureters, then the bladder, then the urethra, and then we have codes for the prostate. Okay, but we're also going to see things again for nephrostomies, for new openings, nephrectomies, for removals, transplantations, getting a new kidney, catheterizations, which we do of the ureters, laparoscopy, again, lots of surgeries can be done through the abdominal cavity here. A lithotripsy, the most common place that we hear of when it comes to getting stones in the body, is in the kidneys, and that's what we do to break them up as a lithotripsy. The ureterostomy. So we can have a nephrostomy, which is a new opening from the kidney to the outside of the body, or a ureterostomy, which is a new opening from the ureter to the opening of the body. We're going to see cystoscopies and cystourethrostomies, and these are the same thing because remember, cysto means urinary bladder. How do we scope into the urinary bladder? We have to go through the urethra. So a cystourethrostomy is the same as cystoscopy because it's the way we're getting it. We're also going to see some urodynamic testing so we can check on the muscles of the bladder. And then as we get towards the male procedures, we're going to see some transurethral procedures in the urinary system because we're going through the urethra to get there. All of the rest of the procedures, the ones where we go through the perineum or we go through the side of the body or open procedures, come from male genital. Most of male genital, we can look up either the name of the body part or the direct surgery. So we can look up penis, testes, epididymis, tunica vaginalis, scrotum, vas deferens, spermatic cord, seminal vesicles. We can also look up things like orchiectomy. We can look up vasectomy. So we have lots of different choices here that we can use to best describe how to find these codes within the systems. The first part of the urinary system does not have any guidelines to it. The first set of guidelines show up on page 340 for the renal transplantation. And as we've been talking about in our other chats, transplantation always has three portions. They always have the removal, the backbench work to prepare the organ, and then the transplantation. Like intestines and like liver, you can either have a cadaver donor or a living donor. And also, like lungs, you could do a unilateral or bilateral cadaver donor nephrectomy. So what we need to know is what is our doctor doing and who is giving the organ or organs. So it tells us renal autotransplantation includes reimplantation of the autograft as a primary procedure along with the secondary extracorporeal procedure like a partial nephrectomy or nephrolithotomy, and these are reported with modifier 51. So again, they're letting us know that autotransplantations means we're moving grafts around, okay? Renal allotransplantations are when we're doing the three different distinct components. So again, our doctor could be doing the cadaver donor nephrectomy, unilateral or bilateral, or the living donor nephrectomy, which will only be unilateral. They could be doing the backbench work. And again, in this case, the backbench work includes dissection of the perinephritic fat, so the fat around the organ, the diaphragmatic and retroperitoneal attachments, any extra pieces of tissue, the excision of the adrenal glands. They usually do not leave the adrenal gland on the kidney when they transplant it. Preparation of the ureters, the renal veins, renal arteries, and ligating branches as necessary. And also, they tell us again that when we're doing these, again, it's whether it's cadaver donor or living donor, we do the same thing, but they are different codes. Okay. It also reminds us that additional reconstruction may include venous arterial and or ureteral anastomoses, again, making reconnections of vessels. And then, of course, the actual transplantation itself. So we need to be careful. Again, who is giving the kidney? How many kidneys are we giving? And right here, it reminds us that dialysis comes from medicine. So keep that in mind. So again, what are we doing when we're doing the transplantation? And again, you can always look up transplantation and then the body part, or the body part, the transplantation. So you can transplantation kidney, or you can look up kidney transplantation. Now, the next section of codes that we have are about dealing with all the different types of catheters that we put inside of the body, usually to hold the ureters open. One part of the catheter ends up in the kidney, the other part of the ureter ends up in the bladder. So this is starting on page 342. It lets us know that percutaneous genitourinary procedures are performed with imaging guidance, like fluoroscopy or ultrasound, and diagnostic nephrostogram and or ureterogram are typically performed with percutaneous genitourinary procedures and are included in 50432, 3, 4, 5, 50693, 4, and 5 as well. So again, what is included in your procedures? Now, it goes on to tell us codes 50430 and 50431 are diagnostic procedure codes that include injections of contrast material, all associated radiological supervision and interpretation, and procedural imaging like ultrasound and fluoroscopy. Code 50430 also includes accessing the collecting system and or associated ureter with needle and again, if they're giving us a note that certain codes might not be reported with other codes, we always are looking for these notations underneath the codes that tell us what can and cannot be coded with them. It goes on to let us know codes 50432, 33, 34, and 35 represent therapeutic procedures describing catheter placements or exchange and include the elements of access, drainage, catheter maintenance, catheter manipulation, and imaging guidance, such as, again, sonography or fluoroscopy, as well as all diagnostic imaging and interpretation when performed. And the reason why is, again, we're dealing with some natural orifices here, so we can go in through the urethra, into the bladder, in the ureter, then into the kidney, okay? And remember to make sure we're in the right place. Ultrasound is nice, it's portable, they can easily move an ultrasound equipment into the surgical room, or like we've talked many times before, the patient could be on an operating table with that x-ray equipment above them, where we can do fluoroscopy. It also reminds us that codes 50433 describes a percutaneous nephrostomy with the additional accessing of the ureter or bladder to ultimately place a nephroureteral catheter. So again, this is a single transnephretic catheter with nephrostomy and ureteral components that allows drainage internally, externally, or both. So when we're dealing with the drainage of issues coming from the kidneys into the ureters, again, we can drain outside the body, which would be externally, or inside the body, which is internally. Okay, so we need to know what's going on. So down here, they're telling us for codes 50430, 312, 345, 50606, 50693, 45, 50705, 50706, the renal pelvis and its associated ureter are considered a single entity for reporting purposes. So 50430 is talking about an injection procedure for an antegrade nephrostogram and or ureterogram complete diagnostic procedure, including imaging guidance and all associated radiological supervision and interpretation, new access. And so again, what they're telling us is that the ureter, so the renal pelvis, remember, is the inside of the kidney itself. That's where the urine is collecting in those calyces in the renal pelvis. So they're telling us that the renal pelvis and the ureter itself are considered one entity for these codes, okay? And that's because a lot of this is imaging. So again, we're using it as basically a single body part. Now it goes on to tell us 50430312345, 50606, 693, 94, 95, 705, and 706 may be reported once for each renal collecting system or ureter access. So 2 separate codes would be reported for a bilateral nephrostomy tube placement or for a unilateral duplicated collecting system for the ureter requiring 2 separate procedures, okay? So again, we can use these more than once because we do have 2 kidneys. Most people, I should say, have 2 kidneys. So again, we can use it if we're doing a bilateral procedure or if we're doing 2 separate collections on one kidney and ureter because we're doing 2 separate access points. And so for these, we need to know, what are we doing? Okay, are we implanting it? Are we placing it? Are we converting it? Are we exchanging it? What are we doing to this tubing itself? And again, what you'll see is you'll see the regular nephrectomies for transplantation are going to usually come from the open procedures. We will have some laparoscopic nephrectomies. Again, a person can live with just 1 kidney. So a lot of times we're not going to be removing and replacing. We may just be removing, but be careful. Every person's situation is going to be different. So we need to be clear what the doctor is doing and why are they doing it. Now I want to talk to you guys about the lithotripsy. So the lithotripsy is on this page, it's a little bit above, it's on page 345. There is only 1 code for the lithotripsy. Remember, tripsy means to crush, litho is stone or crushing a stone. What we do is we either submerge the patient in a water bath, or what's more often used nowadays is it's a water mat that's a couple of inches high. And they send a very set of specific ultrasonic shocks into the kidneys to break up those stones so the person can pass them naturally. However, sometimes we do have to go in and remove. So be careful. What is the approach? Okay. So are we going in through a natural orifice or are we cutting into the body? When we get to the ureters, so remember, it goes kidneys, ureters, bladder, urethra. The biggest problem that a lot of people have is not looking at the spelling, and they confuse ureter with urethra. Biggest thing is ureter does not have an H anywhere in it. So that's one of the ways to visually recognize it. So when we get to the ureters themselves, again, they are the connection between the kidney and the bladder. So this is where, again, we're going to see stent placements and things like that. So code 50606 is an add-on code, and it describes an endoluminal biopsy, like a brush biopsy, using a non-endoscopic imaging guidance, which may be reported per ureter once per day. The code includes the work of the biopsy and the imaging guidance and radiological supervision and interpretation required to accomplish the biopsy. The biopsy may be performed through de novo transrenal access, which is an existing renal or ureteral access, transurethral access, an ileal conduit, or a ureterostomy. Okay, so as we talked about in digestive and respiratory, if there is already an opening, we can scope into that opening. So that's where we get the existing renal or ureteral access, okay? So a ureterostomy and nephrostomy we can scope into. Okay, we also can scope in through the urethra and we can go up into the bladder, then to the ureters. And this ileal conduit, there's a picture of an ileal conduit on page 348. An ileal conduit is basically a a way of being able to continue to allow the person's urinary system to function, but instead of urinating from their bladder through the urethra, the ureters get connected to the ileum, the third part of the small intestine. And again, a lot of times this is due to traumatic accident or injury or cancer. And so if someone has bladder cancer, a lot of times what they'll do is they'll make this conduit, this connection between the ureters and the small intestine, so the person can get all the waste products coming out of the digestive system. So basically the urinary system will dump into the digestive system, and then that will all get passed through the rectum and anus. Now it goes on to tell us though, the service of gaining access may be reported separately. So again, remember, sometimes we're going in through a new opening, sometimes we have to create an opening. For creating an opening, we get to charge for that. Now, a diagnostic pyelography or ureterography is not included in the work of 50606 and may be reported separately. So again, remember, renal pelvis. So this is, again, inside of the kidneys. So we can image the inside of the kidneys, we can image the ureters, and if we're doing that with these procedures to make sure we're in the right place, it is not included in the normal work for code 50606. So we could add an additional code. It goes on to tell us yet again that for these sets of codes, the renal pelvis and associated ureter are considered a single entity for reporting purposes. And again, a lot of times as you go through sections, you're going to see the same types of wording. And that's because what they try to do is if it's the same type of surgery in a slightly different area of the same system, a lot of times they'll use the same wording but different codes. So this is the same exact wording that we already looked at for the single entity for the renal pelvis and ureter, and also when we can code for two separate procedures. Again, if it's bilateral or if we're doing two separate punctures. So again, always be on the lookout for this stuff because again, a lot of it stays the same. So you'll notice it's very similar as you keep going through the same section. So again, we have some pictures of the indwelling stent on the bottom of page 346. So it's directly to the left here. And again, you can see that the top of the catheter or stent stays in the renal pelvis and the bottom stays in the bladder so that we can have access from point A to point B. So we have to remember that these codes, again, are dealing with placement and changing in new accesses of all of these different types of stents. So codes 506, 3, 4, and 5 are therapeutic procedures describing percutaneous placements of ureteral stents. These codes include access, so how we get there, drainage, removing whatever fluid's there, catheter manipulations, moving the catheter around, diagnostic nephrostograms and your ureterograms, again, when performed, imaging guidance and all associated radiological supervision and interpretation. Again, using ultrasound or fluoroscopy to make sure that they are in the right place. So that's what's included. Then it goes on to tell us, when a separate ureteral stent and nephrostomy catheter are placed into a ureter and its associated renal pelvis, during the same session, through a new percutaneous renal access, use 50695 to report the procedure. So again, we need to know how are we placing these stents. So again, we have the injection procedures there. We're going to have the changing, the placement, and the placement with the new access. So again, what are we doing for the patient and how are we getting there? So via an ileal conduit, or are we going in through the urinary tract? So again, you can see right here, 50695, new access with separate nephrostomy catheter. Now, along with all of this, of course, we have to keep in mind that sometimes we have to go into the ureter so that we can open up the area because of possible damage, perhaps due to a kidney stone. So under the repair category, it tells us 50705 and 50706 are add-on codes describing embolization and balloon dilation of ureters using non-endoscopic imaging guidance, and each may be reported once per ureter per day. These codes include embolization or dilation, plus imaging and radiological supervision or interpretation required to accomplish embolism or dilation. These procedures may be performed de novo, so again, transrenal access, an existing renal or ureteral access, transurethral access, so again, going into the natural orifice, an ileal conduit or ureterostomy. The service of gaining access may be reported separately. So how we get there may be reported separately. Now, a diagnostic pyelography or ureterography is not included in these codes 50705 and 50706 and may be reported separately. Okay, so again, we're adding these codes on to other procedures. Other interventions or catheter placements performed at the same setting as an embolization or dilation may be reported separately. So again, they're really just talking about these two codes. So again, we use 50705 with all of these, and we can use 50706 with all the codes they go underneath. So again, we want to kind of keep in mind, what are we doing in addition to? Remember, if your code descriptor does not fully explaining what we're doing for the procedure, we may have to add another code, and in this case, the code may be an add-on. Now, when we are looking at our urodynamics, so urodynamics are starting on the bottom of page 350. Okay, so we're looking at the flow of urine through the urinary system. Now it tells us the following section 51725 to 51798 lists procedures that may be used separately or in many and varied combinations. So they're telling us a lot of these are going to be used together. When multiple procedures are performed in the same investigative session, modifier 51 should be employed. So again, a lot of these will be done at the same time because they're easy to do at the same time. And a lot of this is testing. So they tell us, all procedures in this section imply the services are performed by or under direct supervision of a physician or other qualified healthcare professional, and all instruments, equipment, fluids, gases, probes, catheters, technicians' fees, medications, gloves, trays, tubing, and other sterile supplies be provided by that individual. So that is what is included. When the individual only interprets the result and or operates the equipment, a professional component, modifier 26, should be identified for these services. So again, everything that we generally use to perform these procedures are included in the codes and cannot be coded separately. So we should not be breaking out HCPCS to look up this information. It is included. So again, we have things like cystometrograms where we're measuring the actual urinary bladder and what it can hold. Again, we have voiding pressure studies. We have all different types of studies that we can do. And again, we can do a lot of times multiple procedures in one setting. Now, again, our endoscopies, endo just means within, so that's why endoscopies are in the respiratory system, they're in the digestive system, they're in the urinary system, because each one of these are going within the body. But it's how are we getting there? So again, we have cystoscopies, urethroscopies, and cystourethroskopies. Remember, if we are scoping from the outside of the body in, we have to go through the urethra to get to the bladder. So cystoscopy already includes the fact that we get to the bladder from the urethra. A urethroscopy is just when we go in and look at the urethra. Cystourethroskopy is the same thing as a cystoscopy. And again, for all of these, the diagnostic is included with the surgical. But in this case, they do testing with it as well. So, endoscopic descriptions are listed so that the main procedure can be identified without having to list all of the minor related functions performed at the same time. For example, these are things included in the following codes. urethral calibration and or dilation, urethroscopy and cystoscopy prior to a transurethral resection of the prostate, ureteral catheterizations following extraction of a ureteral calculus, internal urethrotomy and bladder neck fulguration when performing a cystourethropy for female urethral syndrome. And then reminding us when a secondary procedure requires significant additional time and effort, it may be identified by the addition of modifier 22. So what they're telling us right here is there's a lot of things included in these codes, but also that there are some very specific male and female codes. And because the male and female urethra are very much different sizes, we have a couple of codes, just a handful here and there, that will say male only or female only just because of the size of the urethra. And obviously the transurethral procedures on the prostate are going to be male only. Okay, so again, we have the cystourethropy, and then we have all of the other codes. So again, we can remove a foreign body, we can do a lithopaxy or crushing the stones and removing the fragments, and then we get to the ureter and pelvis, where they tell us the therapeutic cystoscopy always includes a diagnostic cystourethropy. So again, remember, therapeutic always includes diagnostic. And then it goes on to report a diagnostic cystourethropy, use 52000. Goes on though, we do not report 52000 in conjunction with 53230 to 53243 and 53256. And that's because all of those codes include a cystourethropy, which is what 52000 is. We also do not report 52351 in conjunction with 52344 to 52346 and 52352 to 52356. And again, in this case, 52351 is a cystourethropy with ureteroscopy and or pileoscopy diagnostic. Remember, we're either doing a diagnostic scope or a surgical/therapeutic scope. We do not do the same type of scope in the same body area more than once. Okay, we always group a diagnostic in with a surgical or a diagnostic in with a therapeutic. So it goes on to let us know the insertion and removal of a temporary ureteral catheter during a diagnostic or therapeutic cystourethropy and or ureteroscopy and or pileoscopy is included in 52320 to 52356 and should not be reported separately. So again, if we're just doing a temporary catheter during that point, then again, that is included because it is temporary. However, if we are reporting the insertion of a self-retaining indwelling stent performed during a diagnostic or a therapeutic cystourethropy with a ureteroscopy and or pileoscopy, we then will code the 52332 in addition to the primary procedure performed and append modifier 51. Why? Because we are now inserting a stent that's going to stay in the body. If it's something temporary, we're just using during the procedure, it's included in the procedure. If we're leaving it in the body, okay, it's going to be something permanent, we do have to code for it. It goes on to let us know for bilateral insertion of self-retaining indwelling ureteral stent, use code 52332 and amend modifier 50. To report cystourethropy removal of a self-retaining indwelling ureteral stent, see 52310 and 52315 and append modifier 58 if appropriate. So again, what are we doing with these scope procedures? We're doing the scope and what? Okay. Now, the last little section that we're going to see before we get to the urethra itself is the transurethral surgery. Okay. Now, the transurethral surgery, there are no guidelines for these, but this is the way to remember it. Transurethral surgery will always be coded in the urinary system because we're going through the urethra, transurethral, to get to the issue. in this case, it's usually going to be the prostate. If we are slicing into the body, if we are going in through the anus, if we're going in through the perineum, if we're going in through the side of the body, if we're going in through the abdominal cavity to get to the prostate, that comes from male genital. So the only reason why the transurethral surgery are here is because we're going through the urethra to get to the prostate. Remember, the prostate is a donut-shaped gland that sits underneath the bladder but around the urethra, which is why we can go through the urethra to get to it. So keep that in mind. Transurethral surgery will come from the urinary system. Open procedures or laparoscopic procedures will come from male genital. And that's really it for the urinary system. The biggest thing with the urinary system is to make sure, what are we doing? Again, are we scoping into the body? Okay, if we're scoping, then where are we going? Are we just going into the urethra? Are we going into the bladder? Are we going into the ureters? Are we going up to the kidneys? We also have to remember this is an area where we're going to be using modifiers RT, LT, and 50 because we need to describe to the insurance company we're putting an indwelling stent in the right ureter. We are removing stones from the left kidney. So keep that in mind. If we're dealing with the kidneys or the ureters, we need to know LT, RT, or 50. All right, so that's one of the big things a lot of people forget about is using the modifiers to describe for the kidneys and ureters. But when we get to the male genital system, there's very, very few guidelines. There's more notations. So I want to talk about some of these codes. So we are on page 361. Now, page 361 starts with the penis, which has the largest section of codes underneath it. But I want to talk a little bit about the differences between what we generally think of as circumcision and another procedure that's sometimes called circumcision. So when we talk about circumcision, we are usually talking about codes 54150 to 54161. Okay, so we're talking about using a clamp or device, like with a regional dorsalpenal ring block, or we're looking for something that's other than a clamp device or dorsal slit. So sometimes that is just an excision of the tissue. Okay, now you'll notice the circumcision using a clamp or other device with regional or dorsal penal or ring block, that can be done for any age. Okay, however, 54160 is for a neonate, 54161 is for older than a neonate. But here is a key thing that you might want to make sure you know. So right here, circumcision, surgical excision other than clamp device or dorsal slit. Okay, so what is the dorsal slit? So sometimes they call it a circumcision. It's not the same type of procedure as we're talking here. A circumcision, usually we're removing a ring of tissue from the glans penis, okay, from the head of the penis, okay, and we're removing a ring of tissue and we're completely excising it from the body. However, sometimes the child doesn't need that. What they need is they need the prepuce, which is the skin that covers the glans penis. That is too tight. And so sometimes instead of doing a full circumcision, they can do a dorsal or lateral slit technique where they make a small incision into the tissue, which releases it slightly enough so that a lot of people think of it as a circumcision, but again, it's not a ring of tissue removing. We're just removing a little tiny piece or opening up an area. And that is right here, 54000 and 54001. This is a slitting of prepuce, dorsal or lateral. So you may want to connect these. Okay, these four right here, or five, I should say, 54150, 60, and 61, and 54000 and 54001. Again, different techniques we use from circumcision. So what is the technique used? And if they say dorsal slit or lateral slit, you better be going up to incision and not under circumcision. Okay, we also have destructions of different lesions of the penis. They are separated out by if they're simple, how many are we removing? If they're extensive, it doesn't matter how we're removing them. We're also going to see things like a biopsy. Another thing right here, 54110, excision of penile plaque for things like Peyronie's disease. This is something we don't really understand how it happens, but some men, as they get older, they start getting a fat plaque buildup, usually on the top of their penis. And what happens is it can lead to a curvature of the penis, which can be very painful. And so what they do is they go in and they can actually excise it. So we can excise it, or as we're going to see over here under the injection, we can do an injection as well. We also can remove a foreign body, and for very extensive cancer and accidents and injuries, amputation of the penis, either partial or radical. I also want to show you guys up here, 54163 is a repair of an incomplete circumcision. So sometimes what happens is circumcision is done within the first few days of the boy's life. As he gets a little bit older, sometimes closer to 1 or 2, he starts having problems learning how to use the bathroom. And so that's when we might have to go back and do a repair after. Now, I was talking about that injection procedure for Peyronie's disease. Again, we could see it here, 54200, 54205. We also have 54220, irrigation of corpora cavernosa for preaperism. So preaperism is becoming much more common because the little blue pill for erectile dysfunction for men has now gone generic. So there are lots of companies making these types of medications now. There always have been, but now there's even more since there's a generic option. The other thing to keep in mind is, although when we think of people using erectile dysfunction medication, we think of older men, it's sometimes also used with younger men as a way to increase stamina or to enjoy yourself more while you are partying. And so that's why there's that warning for every single commercial. If your erection lasts longer than 4 hours, call your doctor and go to the emergency room, because what they end up doing is 54230. They inject the spongy penile tissue so that it basically the penis itself can detumesce. It can stop being so erect because it does become painful after a certain amount of time. But again, you can also see we can do other types of injection procedures, and we can do other types of studies as well to try to find out what may be wrong. Because again, erectile dysfunction tends to come with men that are older. Sometimes it comes with stress, but it can happen in younger men. Sometimes it can happen in younger men because of previous cancer. Testicular cancer is the most common cause of male cancers for men ages 18 to 35. So again, it can affect the rest of the male genital system. Now, the other thing I just want to talk about is under the repairs for the penis, you'll see a lot of things for hypospadias and epispadias. That is when, instead of the urethra coming out the center of the head of the glans penis, it comes out on the bottom if it's hypospadias, or the top if it's epispadias. And so for those, we end up needing to do a series of repairs, sometimes a 1-stage, sometimes greater than 1-stage repair to get the urethra back into position. So what you'll see on page 362 is a lot of different types of hypospadias repairs as well. When you get to page 363, this is where we start seeing procedures on the testes. So we're going to see everything from the biopsies, again, a needle versus incisional. Again, this is where we're going to start seeing the orchiectomies. Again, if they have to, they will remove the testis or the testes for a testicular cancer patient, depending on the extent. They try to save them if they can. And although you can't see it over here very well, code 54660 does talk about the insertion of a prosthetic testis. So we also have prosthetic testes for more of the look. It's not functional, but then you can still have the look if they had to remove a testes. due to cancer. We can do open orchiectomies, we can do laparoscopic orchiectomies, and this is a laparoscopic orchiopexy. One of the other issues that we worry about with young boys is what we call crypticordism. Remember, crypto means hidden. Crypticordism is a condition of hidden testicles. Sometimes in utero, the piece of tissue that separates out the pelvic cavity from the scrotal contents does not close all the way. And so what happens is the testes themselves can go inside and outside of the pelvic cavity. And the problem is that if the testes stay inside the pelvic or abdominal area for too long, once the boy starts getting about age 1, age 2, he will become sterile. He'll still have full use of his genital system, but he will become sterile because there is a reason why the scrotal sac itself is exterior to the body, and that's because the production of sperm requires the testes to be a few degrees cooler than the rest of the body. So if you keep the testes at a very hot heat, it will not be able to produce viable sperm. We'll be able to produce sperm, but not viable sperm, nothing that will be able to make it all the way up to the female egg. And so what we usually do is we watch this as the child grows, and usually we end up doing an orchiopexy, a fixation to make sure that the testes sit properly in the scrotal sac. Here you can see again the epididymis. Remember, the epididymis is the connection between the testes and the vas deferens. So the epididymis itself, again, you can get like an abscess or hematoma. We can do a biopsy of it as well. We can also do an excision of a lesion, or what's more common, a spermatocell. We have to remember that there is a spermatic cord, which basically is a little covering that brings the arteries and veins down into the scrotal sac, into the testicles. And so again, being very careful about what's happening to that area, especially if it's been damaged from traumatic accident or injury. We can also do an exploration, and we can do what we call an epididymovasotomy. So this is an anastomosis of the epididymis to the vas deferens. So again, this is making a reconnection between the two. Perhaps we had to interrupt the connection because of cancer, and now we're doing a reconnection at that point. And that's it. We don't do a lot on the epididymis. Again, the tunica vaginalis, the most common thing that we're going to see here is going to be the hydrocele. So the tunica vaginalis, again, it's helping bring down those vessels into the scrotal sac. What happens is the hydrocele, a water-filled hernia, is very, very common. And there's a super high-tech way that doctors figure this out. They take a flashlight of some sort, usually one of those little pen lights, and they put it up to the tissue, to the scrotum itself. And if something inside of there glows like a light, it's a hydrocele, because hydroceles are completely filled with water, so they will glow kind of like a light bulb. So we can do a puncture aspiration of that, or we can do an excision or a repair. That's about all we do with the tunica vaginalis. When it comes to the scrotum, of course, we might have like an abscess or removal of foreign body because of things that can happen. Again, we can get many things dislodged in our skin. We can also do a resection of the scrotum. Again, perhaps if there was some cancer there. And then we get to the vas deferens itself. So the vas deferens is, again, that connection between our epididymis and our, I should say, the male urinary system. It is the direct connection between the two. So although you can't see it up here, that's what the vaso is. So here's what's interesting. When we do a vasectomy, again, unilateral or bilateral, it includes postoperative semen examinations. It includes 3 of them. That's why I put 3 times. And usually they do it a week after, a month after, and 3 months after, because they want to make sure that it took. There was a huge scandal back in the 90s in California where men were going and getting vasectomies done, being told they were completely sterile, and then finding out they had kids because they never actually had the procedure done. They were just told that the procedure was done. So now they absolutely make sure, but also because this is very similar to what they do to the female genital system. They can suture across it, they can cut and burn it, they can cut and tie it, they can cut and suture it, they can clip it. But again, they want to make sure that the person is sterilized. That's the idea of why we do this. And then, of course, if we have to, we can do a repair, a vasovasotomy, which is when we are doing the reversal of the actual vasectomy itself. Then again, we get to the spermatic cord. So again, we see more hydrocele here. Other lesions, again, because of possible accidents of injury, we might see in this section. Seminal vesicle. Remember, the seminal vesicle is so tiny. There's only a few things that we can do to it. We can make an incision into it, or we can remove it, and that's about it. Because if there's anything else wrong with it, we're usually just going to remove it. But again, we want to be careful because when it comes to seminal vesicles, again, for a bilateral procedure, we use the code with modifier 50. So again, be careful. Same thing with the testes, the lefts, rights, and bilaterals here. Now for the prostate, again, what are we doing to the prostate? So these are not transurethral surgeries. This is everything else but. So again, one of the big things that we're going to keep in mind is, again, these are going to be open procedures, laparoscopic procedures, etc. So if you look on page 366 in your code book, you're going to see the different prostatectomies that we can do, but you'll notice none of these are transurethral. We can do prostatectomies, we can do perennial through the perineum. We can do them suprapubic, so through the pubic area. You can do them retropubic through the back of the pelvic area. We have lots of different ways that we can get there. So keep in mind, if we're specifically going in the urethra, it's going to come from the transurethral surgery under urinary. If it is an open procedure, if we're cutting in to the body from any other area to the prostate, it's going to come from male genital. Okay, there's one last thing I want to say before we end. The other thing that you will see on page 367 is our intersex surgery. We have two intersex surgery codes. We have intersex surgery male to female and female to male, but this is just the genital surgery. So keep that in mind. If we're dealing with the removal or addition of breasts, if we're dealing with removing the Adam's apple, if we're dealing with any other type of reconstructive surgery, that's going to come from other sections. The intersex surgery is just the genital surgery going from one to the other. So keep that in mind. It's usually only one part of that transitional period. All right, guys, good luck. And remember, know where you are when you're dealing with surgery of both the urinary system and the male genital system.